Hi, Dr. Fazen. Um, if you could give us just a little bit of background about who you are.
Well, I'm a pediatrician in Worcester, and we came with my wife, Dr. Lynn Eckert, in the fall of 1975. We had just finished our pediatric training at Johns Hopkins University, and we were looking forward to uh, starting teaching and medical practice in a new community that had not previously had a medical school. So we were trained in along with other in a program, a specific program, Robert Wood Johnson program, to be trained in primary care and primary care as a specialty with skills in epidemiology, statistics, public health. And so during our training, we had a public MPH degree at Hopkins as well as our clinical training. And during our time there, I was involved in epidemiologic research in Guatemala and onchocerciasis, and putting data together and learning how to do surveys and analyze data and, for publication. So our background was in, we thought, a new wave of primary care pediatricians who were public health oriented and community-based in primary care. And so we wanted to go to a new place that was getting started, and that was UMass Medical Center.
So, are you originally from Massachusetts?
No. So
No.
I grew up in Wisconsin and attended medical school in the Midwest at Northwestern, and then served for 2 years in the U.S. Public Health Service during the Vietnam War, and then training at Hopkins after that.
What year did you graduate?
1969.
1969. I'm sorry, what year did you end up coming to University of Massachusetts?
In 1975.
1975. And was your practice based out of the hospital, or did you have your own private practice?
Initially, I came to work on a new health center to help develop a new health center in Uxbridge, Massachusetts. And so I worked on that for about a year and a half or so as a university-based physician, but working in a rural area to develop a health center. That was an understaffed area at that time, federally designated area with insufficient physician nursing support. So that's now a very well-established training site for UMass, and a very important healthcare provider in Uxbridge in the Blackstone Valley.
So what percentage, when you came out of practice, so your residency was at Johns Hopkins?
Yes, and the residency was basically took 3 years. 1 year was an MPH degree, and then 2 years in clinical pediatrics. But part of that time was spent at the School of Public Health. So maybe doing like site projects in, say, Guatemala, working with data, conducting community surveys. But that was done actually in Guatemala because it was onchocerciasis, and it was funded to do that. But the idea is somewhat the same, to do it in a community base, collecting data and understanding what the community-based diseases are.
So what drew you into pediatrics?
Well, pediatrics is very different 40 years ago, and it actually was a very different set of diseases, and many of the diseases were invasive bacterial problems, meningitis, invasive Haemophilus influenza, and pediatrics was much more inpatient with sick children who needed a great deal of support, and antibiotics worked actually for most of those diseases. So during part of our training, there could be a whole floor of patients with invasive diseases, which we now immunize for, but it was quite rewarding to see the effect of antibiotics and fairly immediate effect of children who got sick quickly and then could turn around fairly quickly. And so it had a lot of immediate sort of response that you could really see what you were doing directly. Although it was also complicated, kids were very sick, and it wasn't universal that they could turn around as quickly. So diagnosis, I think in particular, was directed towards meningitis and things like epiglottitis, and much more of a biologic, microbiologic-based disorders at that time.
So was your practice as a pediatrician more for those acute issues, or did you do the wellness checks and the day-to-day?
So what happened then was I helped to get the health center started, and then actually found that I liked community-based medicine, so I moved over to Hahnemann Hospital, which at that time was one of probably 6 or 7 hospitals in Worcester, separate hospitals with their own board of trustees, and actually started as a hospitalist way before hospitalists were identified. So I was teaching in the hospital and then had a small private practice, say in the afternoons, next to the hospital, in a building next to the hospital. So I was doing teaching, rounding, taking care of some sick patients, and at the same time also, I'll just, so in addition to the hospital practice then, utilizing skills from residency and taking care of sick children, I began a community-based practice in an office right next door to Hahnemann. And from that practice, I actually used basic epidemiology and looked at disease patterns in my patients. And one of the things it came up with was a problem with baby walkers. And there actually had been no literature published about baby walker injuries at that time. So I was able to put together interviews with patients and a survey with a student at Pam Felisberto, was a pre-med student in town, and so she helped me to interview families and patients about possible baby walker injuries at home. And these were patients who knew me and were open to discussing family issues and things that maybe people didn't often talk about. So we were able to find, because they were comfortable to explain this, that about half of children were experiencing some type of baby walker injury. And a very large percent of children, maybe 70%, 75% of children between 6 months and a year were using baby walkers. So a large number of children were having injuries, a few very severe, falling down stairs, and so from the hospital side we saw an occasional case, but from the community-based side there were many more unreported and unknown sort of cases at that time. So that resulted in actually the first publication in pediatric literature in the journal Pediatrics that described the spectrum of baby walker injuries. So that was an example of using community-based epidemiology to come up with problems that may not be detected as well using just hospital-based patients.
You seem to have a passion for research. Research, it sounds like that is going to make a direct impact on patients and folks. Where do you believe that came from?
Well, I think it was a research in combination with clinical practice and listening to patients and being trained in epidemiology. So I think it was unusual in those days to have an MPH degree starting off in practice, starting off that way. And so it just, the kinds of questions you ask are more population-based questions in addition to the individual family, but start to put a picture together of what are issues that are not apparent, at the hospital level, but just by office-based epidemiology, which is much more in vogue right now and in fashion for pediatric practices to put their information together, and the American Academy of Pediatrics supports that very actively.
What drew you into medicine?
Well, in a way that's easy because there's a long tradition of physicians in my family. So my actually my grandfather and father both attended the same medical school that I went to. So I think medicine was just always in the family, and something that just seemed a natural fit for me as well.
Now, did your father and your grandfather, well, I would assume with your grandfather that it was more rural type
This
settings?
was in a smaller town, maybe 100,000 people in Wisconsin, in Racine, and so my grandfather was the ultimate general practitioner, starting medicine in 1900, and doing a bit of everything: surgery, OB, pediatrics, and doing it all before antibiotics, for example. And then my father graduated and became a fellow of the American College of Surgeons, so he was a surgeon with, well, before there were boards actually in surgery, but recognized by the American College of Surgery. So, and they practiced right in the house, so the patients were in the home where I lived, in and out, so just that kind of practice that you think of from the turn of the century to 1950s and 60s.
Now, you have a daughter. Do you have any other children?
Yes, we have three children. So our oldest is a teacher, Spanish teacher, and then our daughter is next, and she's a very astute business person, and very active with that, and has an MBA degree. And our son also has master's degrees in his education specialty. And then our third son is a medical student, and he is interestingly pursuing an MD PhD, and the PhD part in epidemiology. So there he is, and he's also overseas in Kenya doing his epidemiology research.
You mentioned that part of your training was in Guatemala, I believe. Um, what what pulled you to the international side?
Well, a very interesting experience in medical school. And I was involved in some research during medical school, and my professor said at the time, that was in 1968, that he was aware of a grant to study diarrhea research in Pakistan, which would be a common problem. And so the next thing I knew, a few months later, I was on a Pan Am flight to Karachi, West Pakistan, and I just couldn't believe it, coming from Chicago and what was very modern, fancy medicine at the time, and all of a sudden in Karachi, and it was just something I could never forget, and sort of tailored my practice, to that, to the international, to consideration for underserved populations and so forth. But that was very early on, with a very dramatic experience in Pakistan.
Now, are you still in practice now?
I've just retired about a year ago from clinical practice, but I'm doing public health. So
Okay.
I'm chairman of the Board of Health in our town of Southborough, and I serve as chairman of the Massachusetts Medical Society Committee on Public Health.
Okay. And how, from the time that you arrived in Worcester and you began the I'm sorry, you said in Uxbridge, it was
It was
the
the
Community
Uxbridge
Health Center.
Community Health Center,
Health
yes.
Center, to now in what you do, how has Worcester changed?
Well, early on, it was very decentralized. As I was mentioning, there were maybe 7 hospitals, each operating on their own, with their own community of physicians and staffs. And so I think you were much more, I think, a little freer to do what you wanted in a way, because it just wasn't highly centralized and organized and defined as to the exact role of a physician. And physicians practiced their own models, their own what seemed to fit them. It was not as much of an organized system as we have today. So it left the door open for a lot of things. I spent some time at WTAG. I did a radio program early on public health issues again on the radio. I started a little program for women to exercise during pregnancy, so in a pool, so it was called the Aquanate. So found teachers, and we just started a program. I didn't. There wasn't any research to do about it because we just let women need to exercise during pregnancy, and one way where they could feel good is in a pool, since it may be awkward to do other types of exercise. So swimming during pregnancy, and so just I think the community was just open to to do new things and new ideas, and it was easier to start something without having to worry about liability issues and things like that. So it was comfortable and very pleasant and open to innovation.
So your patients, when you first moved to Worcester, how many of them had insurance? How much was insurance part of your practice? And I suppose that would differ between the hospital side of what you did as well as your private practice.
Yeah, so my private practice ended up being patients with insurance and more from established families in town, but yet I would also see service patients, they were called, from the hospital. Patients who didn't have insurance showed up at the hospital emergency room. Maybe they were admitted, and then I was there as the hospitalist, so then they might follow up with my practice. So it was mixed practice of both patients without insurance and patients with insurance. And I just I suppose at the time I wasn't a great business person, and I just let it go. Whatever it was low overhead at the time, and you could sort of get away with not worrying so much about exactly what percent are insurance patients and what percent have no insurance or self-pay or other mechanisms. So it was I just had a nurse and myself. There were just two of us. It was a very small operation, but it was more typical. Other physicians had maybe a full day practice, whereas mine was maybe half in the hospital and half in the office.
When did that start to change in terms of insurance being far more of an issue?
Well, it was very gradual, and it just developed more and more. I think I think the change has been much more dramatic with the electronic medical record, because then every diagnosis and treatment is well known and documented, and it either follows the established algorithm or it doesn't, and you become an outlier if you're not following what is expected according to the insurance company or established medical practice. So the concept of uniformity of care is very positive and very good, but it also inhibits some originality and innovation, which could be deleterious if it's not done in a very thoughtful manner.
How did that, or did it, I should say, impact your relationship with your patients?
Well, I would say I feel that during my time, I was working for my patient. My patient was the boss. I was working for the patient, and I was not working for an insurance company or for any third party. So I always felt that was my job, to work for I was working for the patient. That's who I was responding to. And I think that I was fortunate to have, gradually I got into more of a group practice setting along the way, ended up at Milford Hospital in more of a group practice, and again it was, there wasn't a very strict kind of control that I could practice as I saw fit, and I was fairly mature at the time, so I felt I knew what I was doing, at least at that point. So it was very gradual. I think the electronic medical record was probably the main thing that tipped it over to a much more organized protocol medicine, which didn't suit me as well when I was at the sort of the peak of my career, to conform exactly to well-meaning protocols, but not suited for innovation and maneuverability based on each patient, not as suitable. So, and it kind of removed the focus from the patient to the record and to the satisfying requirements of care.
How many years ago did the impact of the medical records, did you start to feel that impact?
I think just as I was leaving, really, and I was just leaving in the Milford practice, Milford Hospital practice. The record was coming in, and that's about the time I was leaving. But I did use the medical record after I left Massachusetts practice, and I was working with the U.S. Public Health Service for a couple of years and used the electronic medical record in the Indian Health Service. And found it somewhat, I mean, so I do have experience with it, although I left as it was just being implemented.
Did that factor into your decision to retire?
I don't think so.
Yeah.
It took about, I think, as I kept in touch with my fellow physicians, it took a few months, 3 or 4 months or so, and they became attuned to it as well. So there was just a little period of disarray for a while there, but not something that was terribly burdensome to them.
Where do you see the practice of medicine going? I know that's a broad question.
Well, I hope it's going towards more coverage so that everybody's included in the population. I think the implementation of the electronic medical record is going to help as far as population-based medicine, improving the outcomes for the whole population, which was where I started off. And so I do think that it's going to be digital and electronic, and if used really in a more of a promoting health and better outcomes for people, I see it very positively. If it's used mainly to cut costs and so forth, it could also be misused in some ways to maybe not as advantageous to the patient and total outcome of health care for a population.
You know, you talked in terms of population-based. How do you feel it's going to impact the individual? I mean, you talked about cutting costs and those.
Okay.
Yeah.
So the record, I think could be used to look at a whole population. You could have 1 million people on the same electronic medical record and figure out, are people in general healthier? All right. On an individual basis, it's going to depend on how physicians use it and making eye contact or computer contact. How does that work out? What time is spent on the computer? I think a lot of physicians are taking the computer home and spending time at home on the computer so that it doesn't interfere with their time with the patient. But it may interfere then with some other important time at home. But
Do you feel that with the electronic record, folks are willing to be as forthcoming as they might have been prior to it?
I don't know. It's hard to say.
Yeah.
I think it's going to depend on individual style of each person, how they deal with it. But the digital natives who are in medical school now, I think they're going to just really flow with it a lot easier and just understand that that's a given, and they'll work with it and move right on. And I think it can be used to improve outcomes overall for a whole practice or a whole population of people.
Now, you have 3 children. How was practicing medicine and balancing home life? How was that, and did it change?
Well, it's a good question, very good question, because we started off just with a beeper and no cell phone. So the beeper went off. If you're driving, you've got to find a phone. You have to have a quarter or a dime, whatever it was. So that initially was something to travel and to be away from a phone. So, but I think also people were more understanding. They knew that's all you had was a beeper, and you didn't have a cell phone, and you couldn't possibly get back right away. So it just went along with what the demands were of practice. So there probably were slower response times, but I think people just went with that as well. So I think it worked out fine. Eventually we had phones and beepers, and um, it just sort of grew along with the society and the mobility of society, and I we just spent some time with our children, and I think they feel that they were attended to as well as needed, and that fit into their lifestyle. Uh, since my wife's also a physician, we had to arrange it so we weren't both on call the same night and going in two different directions with three children at home. But that was something that was easy enough to do.
Um, could you talk a little bit about your experience in residency, what the hours were like, what were the expectations like?
The expectations were that if you wanted to learn about those patients, you had to be there, and you just had to spend long hours in the hospital and really learn about disease and progression of disease, and how it changed with therapy or didn't change, and then you had to readjust your therapy. Um, so without having imaging and much more than just plain films initially, basic labs, it was more on the physician to make decisions with very partial knowledge, and the best way was just to really know how the patient is progressing or not progressing. So I think it just took a lot more time, direct contact, hands-on, feeling, touching, determining that the patient was getting better or not, without a great deal of laboratory to help.
So with now the residency hours having been cut or limited, what is your feeling of that?
Well, I don't know. I don't
Yeah.
really, can't really say. I think that will result more in a concept of team care and sharing that responsibility for that patient, and that it required a little different set of skills to accurately describe what happened on each time period, so that that continuum that maybe was done by one person now is done by a team. And as long as that's done, well, with good information, I think it can work out in a very similar fashion.
Um, Going back to one question about how Worcester has changed, how has the demographics of the population changed in terms of your practice? Did you see a
Yes.
shift?
Well, I'd have to really refer more to, I started off in Worcester, but then actually I worked for a couple of years in Boston, in Jamaica Plain, in an inner-city health center, and then from there back to Milford. So I think the last 15 years or so it was in a community in Franklin, Massachusetts. And the main dynamic there was just growth, in that it was a growing community, and there was just a growing demand for more pediatric services, young families, suburban community. In the inner city, it was a totally different context of patients, and actually at the health center, I don't remember having any white patients, for example. It was all immigrant population, African American and Hispanic. So Worcester, in those early days, was also more less diverse population. Uh, but but I was always interested in a diverse population, having been to Pakistan and then spending a couple of years with the Indian Health Service with Cherokee in Oklahoma during that time after medical school, before residency.
Was now maybe I misunderstood this. Was Guatemala part of your
Residency.
residency? Okay, okay.
And then medical school. So medical school was the Pakistan experience.
Yeah.
And then after medical school, Indian Health Service, and then during residency, Guatemala.
Okay, okay. What was medical school like for you?
Well, it was, going back now, I don't know, we had a new curriculum. I don't know how many new
Yeah.
curriculums there have been in medical school, but I suppose we just happened to start with a new curriculum. It seemed very modern to us. We had a little cubicle for four of us, so we had desks around the cubicle with a refrigerated center area for cadaver and laboratory, wet lab, and so it seemed, this was in the 60s, so it seemed like, wow, this is very modern medicine. Of course, there were no computers, and you know,
Yeah.
so it was a lot of time spent on anatomy dissection, because we had pretty much probably a whole year of anatomy,
Mm.
if I remember correctly, and um, that was a major part of it, I think, much more than now. But and then book learning.
Mhm.
Um, um, Even the medical journals, I don't remember as being as important in those days. Certainly there were journals, but it was mainly, I think, textbook learning, and then lectures, and then anatomy and histology.
Do you still remember your cadaver?
I don't remember all the. No, I mean, it was male. I
Okay.
remember that part. And one other thing that was interesting was the electron microscopy
Ah.
was just coming in, so we actually had quizzes on, what's this, my goodness, look at that, you can see right into the cell, isn't that something,
Yeah.
and right into the nucleus and right into the cytoplasm. So I do remember that as really fascinating to us, to the idea of electron microscopy.
Yeah. Do you happen to remember how much it cost to go to medical school?
Well, this is a private school, so
Yeah.
I don't remember in those dollars. I expect it's probably about the same now for private schools, whatever the private schools are now. So I think it would probably be about the same if you adjust for cost. Expensive, yes.
How did that, was that a burden when you came out? I mean, how did you get the funding?
You know, I hate to say this, but when when I go back for my reunions, it's all white men, from my class. It's about 90% white men. They tended to be from above average economic families. I think that we didn't, I don't, I think the tuition part was not a huge problem for most people. It's just the way society was in those days. So 10% women and all others is a very, selected group of white men. So it's a little embarrassing to go back to the reunion these days.
Yeah, yeah. Okay. Now, with the being right on the switch with, the government being more involved in medicine and insurance and all of that, what is your feel on the role sort of government within healthcare?
Well, I think a major role of government is the Affordable Care Act, which is the expansion of coverage to the whole population, or almost the whole population. And I just see that as critically important for the overall health of the population. And I go with the data, which is that we have very mediocre results on the basic indices, infant mortality, um, life expectancy, compared to the rest of the industrialized world. And we just don't cover everybody, and we don't attend to everybody in the same way, because the coverages are so different and variable or non-existent. So I'm very favorable towards the Affordable Care Act, which expands the coverage and allows everybody access to hopefully appropriate preventive as well as clinical care. Yes, there are certainly problems with it, and it's going to be difficult to implement and find enough primary care doctors and much of that. But at the same time, hopefully we can cut down on overuse of medicine and unnecessary testing, and reduce some costs that where we spend money just for medical legal reasons, or just because we want to order a test. I think we do need to reduce our expenses. I think that can be done safely for patients and improve outcomes, and use the money that we spend, which is a tremendous amount of our gross national product and much more than other countries in the industrialized world, twice as much, and have outcomes which are better than what we have, and we should be at the top of other nations with total population outcomes.
How, to what degree would you be comfortable with the government in the physician's office in terms of impacting how a physician practices?
I don't know if that's a trick question or not,
No,
but
it wasn't meant to be.
I mean, nobody wants the government to be too, in your office or in your home or, anywhere where the government is that obvious. But um, how comfortable would I be with more regulation of the practice? Maybe that's how I might interpret that. I just think it's inevitable. When I started, my wife and I started, we could innovate, and we could just use the hours and hours we had spent in our hospital and medical school training as our understanding of patient care, and use that experience going forward to sniff out problems, and that clinical kind of judgment was very important, and I think we have moved away from that. Probably not everybody has the same clinical judgment, and it doesn't fit everybody, and your judgment isn't right all the time either. So I think we move towards a more organized, regulated approach, which is going to have, I think, a positive outcome for the total population. And I think physicians will work within that as time goes on, and maybe develop special areas of interest. A lot of physicians nowadays, many physicians nowadays, may work part-time and then have another part-time to work with a free medical clinic, or work overseas, or to do some other types of practice. So I think physicians will find their way through that. I think it's going to be more organized, more regulated, for the better results, for population results. Make sure that people get their preventive services, immunizations, so forth, that are needed, and maybe a little less personal decision making by physicians, because it's going to be by algorithms and what's the appropriate thing to do. So I think that'll be positive, and then physicians will just have to work within that and find environments where they maybe have some more individual expression. Either they're doing some research or some innovative clinical practice models.
Well, the final question, you mentioned that your son is a medical student. So it's kind of a combination of what advice would you have for medical students, and if you wouldn't mind sharing a pearl of wisdom that you gave your son.
Well, I certainly, he did ask me actually this past weekend about that. He is overseas, and he was home for this particular time, and I was still very enthusiastic that I think it's a wonderful field to be in. You just, the kind of trust and confidence of another person in you, that you will put their interests ahead of any other interests, and serve them, is just something that you can't find anywhere in society. And so I very much encourage him to continue on, and to find his way through this electronic and new medical arena that we're in, because it's at the bottom. It's about people and making people better, and caring for people, and it's just a very personal and rewarding way to spend one's career. So as far as a pearl of advice, I think just to honor your patient, and just remember that you are working for your patient and not the government or the insurance company or anybody else, but you're working for your patient, and that's the outcome that you want to make sure is positive and the best result
Wonderful.
that you can provide.
Wonderful. Thank you very
Thank
much for
you.
your time.
Thank you.